applause. And our final of the three talks in this session is from Courtney McGregor, a Public Health Officer with the South Eastern Sydney Local Health Public Health Unit, and her most recent work includes leading a residential care, aged care vaccination project, so very much in the line of what Paul's been talking about and in fact done in the past in Canada anyway. And that this project identified practical solutions to improve coverage amongst aged care residents. So Courtney, thank you very much.
Good morning, everyone, and thanks for the opportunity to be here today. And yes, this is a great introduction, Paul, and I assure you that we're here, we do care about our older people. So I'll just begin by acknowledging the important role that our national and state level systems do play in shaping Australia's immunisation landscape, including the policy, surveillance and funding arrangements. And the work I'll present today is intended to complement those systems by focusing on what happens at the operational interface, so where policy intent meets the day-to-day delivery in residential aged care homes. Before moving on, I'd just like to formally recognise that this project was conducted on the traditional lands of the Eora and Darawal First Nations people and pay my respects to elders past and present. I'd also like to acknowledge the Central and Eastern Sydney Primary Health Network for their initiation, funding and collaboration of this work. So why focus on aged care? Residents in aged care are among the most vulnerable Australians to vaccine-preventable disease. And in 2024, and from data we've seen this morning as well, coverage from all 4 recommended and funded vaccines, so at the time this was just for COVID, influenza, pneumococcal and shingles, remained below the expectations. And importantly, pneumococcal and shingles coverage was not and is still not routinely reported specifically for aged care residents, and that limits the visibility of the problem. And so this raised the practical question: why does uptake lag in a highly regulated, relatively well-resourced and effectively captive setting like aged care? In theory, this should be an ideal setting for vaccination. Residents are known, they're eligible, they're funded, and they're stable in one location. So our work focused on where delivery systems were breaking down in practice and what could be improved at each facility or home level. So this was a large quality improvement initiative conducted across South Eastern Sydney Local Health District. The district is located in metropolitan Sydney and comprises 97 aged care homes, accommodating nearly 8,000 residents. And it serves an overall population of almost 1 million people, with around 40% who were born overseas. This project was delivered in 2 deliberate and connected phases. First, to understand the barriers and enablers to vaccination delivery, and then second, to design and test solutions informed directly by those findings. And the findings were published across 2 papers, simply just due to the scale and scope of the work, but it was one continuous body of work. And to understand the problem, we gathered perspectives from key stakeholder groups, including aged care staff, residents, family members, GPs, as well as our district's in-reach geriatrician and nursing teams. And in total, we collected input from 238 participants. We used the 5 A's framework: access, affordability, awareness, acceptance and activation, to identify the barriers and root causes for gaps in vaccination coverage. And importantly, we focused on the operational processes rather than vaccine attitudes, allowing us to really map where the delivery was breaking down in practice. So phase 1 showed us that the barriers were largely operational and systemic. So these included limited access to immunisation histories, significant delays in obtaining consent, poor vaccination tracking systems, and unclear roles and responsibilities of who's tracking, whose responsibility it was for tracking which residents were up to date. And there were also constraints where staff capability actually exceeded what organisation policy allowed for. So for example, many homes employed nurse immunisers but did not actually permit nurse-led vaccination for residents. And often frontline staff were not supported to store vaccines on site, aside from the seasonal influenza vaccine. So the clear message was that sustainable improvement needed some system-level support and policy change. So phase 2 translated those insights into action. We developed a suite of practical interventions to directly address the barriers identified in phase 1, and that was particularly around online consent, vaccination planning, and tracking. And these were also supplemented by supportive resources and education. And notably, these were not generic tools. Each was deliberately designed to address a specific issue identified in phase 1. So we'll go through those in detail now. To address delays in consent, we developed a Microsoft Forms online consent template featuring all 4 funded and recommended vaccines, embedded links to vaccine information, and facility-level adaptability and tracking of those responses. So what it did was allow for residents and families to provide or decline consent online, and it was designed to be completed just once for the resident's stay, with the option to withdraw consent at any time, so effectively shifting from an opt-in to an opt-out model. But critically on this form did not replace the provider's responsibility of pre-vaccination assessment on the day of vaccination. It was simply a way to collect and record vaccination intent. And we also had this form translated into additional languages. To overcome fragmented approaches to vaccination planning, we developed a vaccination action plan toolkit informed by our staff questionnaires. And it included guidance on accessing resident immunisation histories, communication with residents and families, as well as clinic coordination, cold chain management, and AFI management. And each aged care home received a tailored version of this action plan, including their site-specific barriers and recommendations to overcome these. To support vaccination tracking, we developed an Excel-based vaccination tracker using air data for each home. And this tool flags residents who are overdue for vaccination, and it provides facility-level coverage summaries as well through an auto-updated cover sheet. And this can be updated locally and maintained by the aged care staff. So staff, after receiving this vaccination tracker register, that staff consistently reported that this transparency enabled them to organise clinics more effectively and help to keep their residents up to date. Gaps in vaccination information and resources were also identified as a key barrier. And residents and families told us that they wanted information in simple language. And staff also highlighted that there was a lack of translated resources to support their residents from the many culturally and linguistically diverse backgrounds in our district. So in response, we developed these low literacy fact sheets and had them translated to 9 priority languages. And they covered all 4 of the vaccines and had links to additional information like the NCIS, frequently asked questions, if anybody wanted to click through and find out more information. And so to support the use of these tools and resources, we also delivered online and face-to-face education sessions. Again, covering things like the vaccination recommendations, how to access immunisation histories using AIR or My Health Record, how to communicate with vaccine-hesitant individuals using the Sharing Knowledge About Immunisation or SKY resources, as well as, again, that cold chain and AFI reporting and management. And importantly, this education, it was delivered through ongoing engagement with staff to support the implementation. And this sustained support is really critical, particularly given the wide variation across homes in their size and their staffing and internal systems. And then in 2025, we also conducted on-site cold chain audits with all of our homes that were holding New South Wales had state vaccine accounts, just to ensure compliance with the Strive for 5 national vaccine storage guidelines. And when these audits were repeated earlier this year, only around 40% of our homes are currently storing their own vaccines, and that's dropped off quite a lot. And this also highlights a continued reliance on external providers to supply vaccines for clinics, and that was something that was highlighted as a barrier for these providers coming in and vaccinating residents in aged care. Okay, so as a result of our project, we successfully advocated for direct access to air for all aged care homes, and that was implemented by the Commonwealth from May 2025. We were also to increase the NIP vaccine ordering limits via the State Vaccine Centre in New South Wales, supporting facilities or providers that were coming on site to run vaccination clinics. But one remaining gap that we were unable to progress, despite our best efforts, was enabling aged care homes to directly order COVID vaccines through the National Vaccine Operations Centre, or VOC. But we are hopeful that the upcoming changes to the COVID program from October this year might address that ongoing barrier for any of those homes who are wanting to order and store their own vaccines. So moving to our outcomes and vaccination coverage analysis. So for this, we asked each home to provide a list of their permanent residents, and of our 90 participating homes, 85 of them provided a list to us, which totalled almost 7,000 residents, which is almost a whole of district cohort. And we're very pleased with that. And at the end of the intervention period, vaccination data was re-extracted from AIR using the AIR 12A database exchange report. And residents who did not appear in AIR at follow-up, of which was about 1,800, were considered deceased, and they were excluded from both the pre- and post-intervention analysis. So this left us with around 5,000 residents, or 74% of the original cohort being included in the final coverage analysis. So to our outcomes, we had some meaningful improvements in 3 of the 4 vaccines across our large cohort. So over a 14-month period, shingles saw the largest improvement, followed by pneumococcal vaccination. And remember, these were the 2 vaccines that were least routinely tracked prior to the intervention. And this highlights a key issue. The staff can't act on gaps they can't see. So introducing the vaccination tracker made the deficits visible at the facility level, improved awareness of who was overdue for what, and allowed those residents to be caught up. And it also challenged a common assumption that we've found during this project, that residents are already vaccinated against shingles or pneumococcal prior to admission to an aged care home. It's simply not the case. And now to COVID, where coverage declined when a 6-month reporting interval was applied. But interestingly, if you look there at the 7-month interval, it remained relatively stable. And that we looked at it from a 7-month interval to allow just that 1 month period of grace. Because a 6-month window is pretty tight. Vaccination requires the coordination, the consent processes, provider availability, and it's also disrupted by outbreaks within homes. And then again, you want to avoid vaccinating residents too early. And most residents in aged care are recommended to have a COVID vaccine every 6 months. So as a result, applying a 6-month reporting interval can actually make a well-functioning system appear to be underperforming, and this example shows that quite well. Okay, so the data that I just presented was current as of October last year, so that's about 8 months ago. And here I just want to show you a case study of one of our homes that highlights how effective and sustainable the project tools and resources have been over a 22-month period of time. So between July 2024 and May 2026, for this home, COVID increased from 35% to 78% using that 7-month interval. And while influenza remained pretty stable, pneumococcal increased from 11% to 82%, and shingles increased from 3% to almost 70%. So these are substantial and sustained improvements over almost 2 years. And then hopefully over the next 2 years, what we'll see is that RSV vaccination rate, currently sitting at 3%, is up around the 70 or 80% mark as well. And we've already had reports from many of the staff in the homes in our district, and they're actively organising RSV clinics at the moment, which is really good. Okay, so as part of evaluating our intervention, we also sent a survey to the staff of all participating homes. We had 25 responses, and findings included that all respondents found the vaccination tracker register useful. 88% found the tailored action plans helpful, and 84% were very satisfied with the project as a whole. And notably, 45% of these respondents identified missing records in the air data that we provided them via the vaccination tracker when compared with their internal records, which, as I'm sure you could understand, is so frustrating for the frontline staff. And what that reinforces is that data completeness remains a system-level issue rather than a failure to vaccinate residents. And it also highlights why facility-level access to the air is critical, because without it, the aged care staff must rely on others to provide vaccination histories for their residents, and they don't have the ability to audit or correct any missing records in our national database. Some good news, many of the tools developed through this project, including the online consent template, the vaccination tracker registers and the fact sheets, are now available on the New South Wales Health website. And the New South Wales Ministry of Health has also taken responsibility for these resources and begun updating them, including the recent addition of RSV materials and the upcoming changes to the adult schedule for pneumococcal. We've been in talks with the NCS team responsible for the Sky resources, and as mentioned earlier by Margie, that there is an intention to include adult content and then later down the track specifically content for aged care settings, which is aligned closely with the needs identified here as well. And our work's generated lots of conversations with the Aged Care Quality and Safety Commission, as well as prompting other jurisdictions around the country to look at their homes. And there's also a growing body of research in this space at a national level, which is also always very helpful. So together these represent important steps, but as always, there's more work to be done. So although aged care homes can now apply for direct access to air, homes in our district are still facing barriers due to application complexities, as well as organisational constraints, including the perception that they are not immunisation providers. And this is something that we've heard from our frontline staff. Their head offices say, look, we're not immunisation providers, therefore we're not going to apply for access to air. So we need to educate them as to why they need this access. Data usability is also a key issue. While accessing individual records is helpful for new admissions or for smaller homes, it becomes much more challenging at scale. And in this project, we used the AIR12A database exchange report to create the vaccination tracker registers for individual homes, as well as to determine vaccination coverage rates for the whole resident cohort. But it required complex coding to generate facility-level insights. And it's really impractical for frontline staff to be expected to try and replicate that. And there's also no AIR reports specifically for aged care organisations like there are for other vaccination providers. But this would be quite tricky, I do understand, and this would be hard to achieve, especially as a lot of residents, as we've found, do not actually update their address once they move into an aged care home. It tends to stay at their home address they were at before. So these ongoing challenges highlight that access alone is not sufficient, and data needs to be usable at the point of care. So to address this, software regularly used in aged care systems needs to be better integrated with AIR, enabling real-time reporting and visibility of coverage across all of the vaccines for individuals, as well as the resident cohort in each home. So if there's any clever IT people here today, please put your thinking caps on and do something amazing. There is also ongoing education needs that can present CPD opportunities for aged care staff as well as other healthcare providers. So there's a clear need to improve awareness of pneumococcal, shingles and now RSV vaccination among all stakeholders, including the ongoing schedule changes and the fact that many residents are not actually vaccinated prior to admission to aged care. Education is needed on what constitutes appropriate consent for vaccination, including written options, verbal or online approaches. And we in our district have also received ongoing requests for education for residents and families around the need for ongoing COVID vaccination. And this might require a bit more engaging and creative approaches. And anybody who was at the CDIC conference yesterday afternoon and saw the debate about influencers versus health professionals, we need some creative approaches. So please, someone who's clever in that space, get onto that. And there's also a need for robust education on vaccine storage and cold chain management in aged care homes if they're planning to store vaccines on site. And importantly, addressing these gaps requires ongoing education and practical support, not just once-off training or a 1-hour HETI module. In our experience, our aged care workforce is largely culturally diverse and the staff turnover can be high. And these things need to be taken in consideration when designing and delivering education for aged care staff. And then there's also this emerging evidence, including work from Brisbane South PHN, showing that on-site in-person education significantly improves aged care staff knowledge, skills and confidence around vaccination. As I mentioned in my last slide, what constitutes appropriate consent, there's confusion around this, and it extends beyond frontline staff to organisations developing consent policies. Systems like CARMI, which is used in the New South Wales School Vaccination Program, demonstrate what is possible, but a similar endorsed approach does not yet exist in aged care, and this is another call to action for IT experts out there. Organisations need to be reassured that online consent is acceptable, and frontline staff are enthusiastic about this time-saving benefits of this kind of consent, but at present, corporate decision-making is still getting in the way. And then as GP engagement around vaccination in aged care declines, as reported by our frontline staff, pharmacist immunisers are actually increasingly filling this gap. However, strengthening internal capacity through a nurse-led vaccination model is also critical. And this could be supported through nurse immuniser scholarships to upskill staff, government funding for dedicated nurse-led vaccination roles, similar to the ACOP program, or advocacy at the organisational level to enable policy changes in favour of nurse-led vaccination. And we've actually seen how effective this can be. One of our homes is a dementia-specific site, and they use a nurse-led model of vaccination, and they have one of the highest rates of coverage across their residents, despite the challenges seen in a dementia cohort. So with the right policy settings, training and support, our homes are very well placed to deliver vaccination autonomously in a patient-centred way. So in summary, this work shows that when the barriers in aged care are clearly understood, they can be addressed in ways that significantly improve vaccination delivery for some of our most vulnerable residents. And the focus now needs to be on sustained action, ongoing implementation and support, particularly as the vaccine schedules continue to evolve. One more slide. Sorry, one little last bit, just to our next step. So we've already expanded our work. We're doing a current initiative called Village Vax, and that's actually exploring the behavioural and social drivers of vaccination in our retirement village populations, where the average age of a resident is around 80 years old, and between 30 to 55% of these residents eventually transition into our aged care homes. And then more broadly, there's a need to shift our focus upstream, which is things that Paul spoke about earlier. And there are opportunities that exist to extend this work into other settings, capturing other vulnerable populations. In our team, we've got the models and we have the ideas, but as always, the scaling and sustaining this work requires ongoing investment and funding. And unfortunately, that's the barrier we're currently facing. Thank you, and if you want more information, our contacts are there.
If I could have Margie and Paul up, we'll do a panel, and I'll start with a couple of specific questions to you, Courtney. And anybody, please come up to the microphone for any of the